Mr. A.R., who is a 60-year-old male, came with complaints of blurring of vision on 10/2/2022, sir. He had vertigo from 11/2/2022, weakness of left side of body on 13/2/2022, sudden onset of painless bilateral blurring of vision, no double vision. He fell in washroom and was found to have weakness of left side of body and drooping of both eyelids, sir.
So what do you think about the blurring of vision?
Sir, he is a 60-year-old male. Blurring of vision could be age-related presbyopia, diabetic.
Unilateral or bilateral?
Sir?
It can be unilateral or bilateral?
Sir, it will be bilateral, sir.
It can be either?
It can be either. No, sir, it will be generally unilateral, sir.
This particular patient had blurring of vision both eyes?
Yes, sir. Sudden onset.
Sudden onset. What do you think?
Yes. Sir, any vasculitis, sir?
Affecting which blood vessel?
Central retinal arteries.
Will it affect both sides simultaneously?
It can, sir.
How?
Because it's a inflammatory process involving the
both eyes, central retinal artery occlusion simultaneously. Possible, but a very rare possibility.
Okay, sir.
Any other option for you?
Sir, any tumor in the brain?
Suppose the patient has got hemianopia.
Hemianopia.
We complain of blurring of vision?
Sir, yes, sir.
Okay. If the patient has got an occipital lobe lesion, can the lesion be bilateral?
Yes, sir, it can be bilateral.
It can be bilateral. So, this gentleman had a good onset of blurring of vision, both eyes, on 10th of February, and he remained so till next day. What happened next day?
Next day he had vertigo, sir.
So, is it central or peripheral?
Seeing his complaints of vision, it could be a central vertigo, sir.
How do you differentiate between the two?
Generally, peripheral vertigo will have ear signs, sir, ringing sensation in the ear, and it will be positional.
Deafness, tinnitus may help.
Yes, sir.
Positional may help. And when you examine, what is the difference between the two?
Generally, peripheral vertigo will have only nystagmus towards one side, sir. But a central vertigo will have nystagmus on both sides, and also in the central gaze also may have nystagmus, and vertical nystagmus can be there.
A peripheral vertigo, nystagmus, you will have what is called as fatigability.
Yes,
it
sir.
It will not persist. It may be very transient.
Okay, sir.
And vertigo also disappears when you sit in a particular posture for a couple of minutes.
Okay.
And only when you change the posture, you get another episode of vertigo.
Okay, sir.
Then next day, what happened?
Sir, next day he developed weakness on the left side of the body, sir.
Hemiparesis.
Yes, sir. Hemiparesis.
Okay. Then what happens?
Then his vision completely lost, sir. He had lost his vision. From blurring of vision to the vision has drastically worsened, sir.
Okay. Then what happened?
Then there is double vision is complaining, sir. There is no double vision since he has lost vision.
Okay, that's right. Yes.
And he fell in the washroom and he was found to have weakness and drooping of both eyelids, sir.
What do you make out of this bilateral drooping of the eyelids? What are the different causes for bilateral drooping?
Bilateral.
Many causes, no? Can you enumerate few at least? In myasthenia gravis, can you have bilateral ptosis?
Sir?
Myasthenia gravis?
Yes, sir.
Yes. Then
nuclear palsy also.
Any myopathy can you have?
Yes, sir.
Which
all mitochondrial myopathies.
Any other myopathy? Oculopharyngeal myopathy?
Yes, sir.
Any acute poisoning you can tell?
Yes, sir.
What?
Sir, and even the lesion in the Westphal nucleus.
That's good. Simple snake bite, no cobra.
Snake bite, yes.
What about Wernicke?
Sir, one encephalopathy, sir. Yes, sir.
Thyrotoxicosis
Thyrotoxicosis, there will be lid retraction.
with the myasthenia, no?
Yes, sir.
Yes. Apoparesis, yes, you
Yes.
can have. Myotonia dystrophica,
Yes, sir, it can happen.
you can have. And as you said correctly, third nerve. So,
Okay.
how do you get bilateral?
Nuclear involvement, sir.
So, why nuclear produces bilateral?
Sir, since the both cross, sir, there will be internal decussation.
So, bilateral is because of there's a same, both sides are supplied by the central nucleus, no?
Yes, sir.
Yes. So, you think this is the differential diagnosis for us.
Okay, sir.
Bilateral drooping of the eyes, hemiparalysis, blurring of vision, vertigo. So, where do you anatomically localize this lesion? You are permitted to do that. History wise, I mean.
History-wise, sir, cerebellar involvement is there, sir, here. So, posterior circulation, sir.
Very good. Posterior circulation is the possibility. That's very good. Very good. So, what do you mean by posterior circulation?
Sir, posterior circulation is vertebral artery, vertebrobasilar circulation.
What are the areas supplied by that?
Generally, all the cerebellum and the occipital area, sir.
Brainstem as such, no?
Yes, sir. Brainstem also, sir.
Occipital lobe, part of the temporal lobe. What about thalamus?
Thalamus is by middle cerebral artery, sir.
No. So branches of posterior cerebral, no?
Okay, sir.
Okay. So, you answered most of it.
Yes, sir.
No previous history of TIA.
Okay, sir.
And he is known to have diabetes and hypertension for the last 15 years.
Okay, sir.
And 3 years back he had similar episode but recovered from it.
Okay, sir.
Okay. On examination,
BP was 180 by 80, sir.
what do you think?
Hypertensive thing causing a hemorrhagic stroke. Pulse rate is 85 per minute. Higher motor functions normal. Cranial nerves normal. Finger counting only both eyes.
First cranial normal, second the equitation is like this.
Fundus shows evidence of diabetic and hypertensive retinopathy. There is bilateral complete ptosis.
So, does the word complete help you?
No, sir.
Complete means usually third nerve is affected.
Yes, sir.
If it is horner, incomplete.
Sir, I didn't get you, sir.
Horner syndrome is incomplete.
Yes, sir. Incomplete.
Myasthenia usually it is incomplete.
Yes, sir.
Apoparesis usually incomplete. Ocular myopathy is again incomplete.
Yes, sir.
And when you lift the eyelids,
In myasthenia, there will be like exertional.
no, that's okay. And what's happening here?
Complete ptosis, sir.
And after that,
On lifting the eyelid, divergent squint of right side. Squint towards right side.
what does it mean?
On lifting the eyelid, there is divergent squint of the. Sir, maybe divergent squint means like lateral medial rectus is affected.
So third nerve palsy.
Third numbers.
So that points that this patient got third
Third.
nerve palsy. Okay.
The right eye is abducted, no other movement possible. Intorsion not seen on looking in and down.
How do you look for fourth nerve when there is third nerve palsy?
Then we have to adduct the eyes and check, sir.
And look down. Adducted position, look down.
No, yes.
And look at one of the blood vessels and see whether it's intorsion or not.
Okay, sir.
That's not the, okay.
Left is not abducting in central position.
So right is not adducting, left is not
abducting.
abducting. Can you see anything here?
Yes, sir. There is a patient.
So patient is trying to look to the right side.
Okay, sir.
Okay, and you find that the left eye is not able to adduct. Simultaneously, this one is not able to. So, can you read it?
Yes, sir. Pupil right side dilated and fixed, left side fixed, normal. Causes of anisocoria.
The right side eye is dilated and fixed.
Yes, sir.
So what
Left
does it
side
mean?
is normal.
What does it mean?
Sir, unilateral eye.
Third nerve palsy.
Third nerve palsy, but any tumor or mass lesions.
Mass lesion is also possible.
Yes.
It's also possible. Okay. Then,
Hemorrhages, sir.
okay. What are the cause of anisocoria?
Hemorrhage tumors.
Anisocoria commonly indicates there can be Horner syndrome,
Corners.
but third nerve palsy.
Okay.
There is impending coning, no?
Yes, sir.
Okay. There are different causes for anisocoria. When do you say anisocoria is present?
When there is a difference in pupil size for more than 1 mm, sir.
2 mm.
2 mm.
2 mm. Okay. So, what is Addis pupil?
Sir, tonic pupil.
Oh, that's right. What is it? It is a type of pupil seen in people who are a bit obese.
Okay, sir.
And you find one pupil is dilated. And the reaction of the pupil to different reflexes will be slow. On the same side, you may find that the reflexes are deep tendon jerks are sluggish. Does not have any importance that way. There is no localizing value. It's not a part of any particular disease. You may take it as a normal variation.
Okay.
And next one.
All sensations of left side of face are lost. And where do you localize fifth nerve?
Yes. All sensations are lost on the face. Where do you localize?
All sensations are lost means it will be in the brain, outside, sir, like outside the brain stem.
Outside the brain, you mean all the 3 branches are affected, you mean?
Yes, sir. V1, V2, V3.
What about the trigeminothalamic tract?
Yes, sir, it can also be involved, sir. Left continued. Left 7th nerve shows
Lower motor neuron.
Lower motor neuron and
lower motor neuron palsy on the left side. 7th nerve. So 7th is on the left side, 60 is on the left side, 3rd on the right side, bilateral signs.
Okay, sir. Sir, it's like
It's
non-localizing, sir. Like could be most probably you should suspect ICH.
Pardon?
Sir, lesions are like non-localizing. Maybe it could be raised ICT passing.
Let us go to the 7th nerve. So, what are the features of 7th nerve palsy inside the pons?
7th nerve palsy inside pons, sir.
Yes.
There will be.
If it's nuclear lesion, what happens?
There will be like facial weakness and hyperacusis, loss of taste.
What are the adjacent structures for 7th nerve nucleus?
6th, sir.
That's right. So what is happening in this patient?
Yes, sir.
6th and
6th and
7th are
7th are affected.
Affected, yes. So you got the localization there, no?
Yes, sir.
Yes. Other cranial nerves are normal. The motor system
Motor system, left leg everted, externally rotated.
Yes.
Hypotonia present on the left side.
Yes.
Grade 0 power on the left side.
Yes.
And deep tenon reflexes absent on left side. Plantar bilateral extensor.
Yes. So what does it mean now? What does bilateral plantar indicate to you?
Bilateral plantar extensor indicates central lesion, sir.
Central means?
Like
No, we
human.
put together when there are lower cranial involvement and when there is vertigo as the symptom.
Yes, sir.
And when you have got this bilateral extensor plantar, you think it's a brainstem stroke.
Yes, sir.
Unlike a carotid stroke where you get unilateral upgoing plantar, here a bilateral upgoing plantar.
Yes, sir.
No. Yes.
Continued. Sensory system, hemisensory loss on the left side.
So, not only on the face, body is also affected.
Yes, sir.
Yes.
There is no Brui hurt. Other systems are normal. Anatomical localization.
Yes. So, localization as per sensory wise, motor wise, and as per cranial nerves. As
Yes,
per
sir.
cranial nerves, you already said system of the nucleus, so pontine lesion. Okay.
Yes.
Motor wise, there's hemiparesis.
Yes, sir.
Sensory wise, how do you account for that?
Sensory wise, sir.
There's a hemisensory loss.
Yes.
So where is a lesion localized and when there is hemisensory loss?
Hemisensory loss means brainstem, sir.
So it should be at a point where spinothalamic tract and trigymnothalamic tract are joined together.
Yes, sir.
So from that point onwards, can it be thalamus?
Yes, sir.
So it can go up, no? Anywhere.
Yes. Yes, sir. Yes. Both sensory systems in thalamus.
This
Yes.
is the localization you're talking about. The facial nerve nucleus,
Yes, sir.
abducens nucleus,
Yes, sir.
and it's winding around, no?
Yes, sir.
So that's what happens. That's what happens. Here is a lesion localized here.
Okay, sir.
Okay. So provisional diagnosis.
A brainstem stroke. So CVA is vertebrobasilar stroke involving the brainstem, midbrain, pons, and possibly occipital lobe.
And how do you investigate this case?
Generally, we should do a CT brain, sir. CT brain and CT angiogram.
So we did everything and this is the result coming up.
Yes, sir.
Okay, MRI brain, let us see. This is a brain, MRI.
Okay, sir.
What can you make out?
Sir, there is hyperintense lesion noted in the right occipital.
What is this area?
Midbrain, sir.
Midbrain. Yes, what is this area?
That is
Thalamus.
thalamus. Yes.
And what are these areas?
Occipital,
Okay, and this area?
cerebellum,
It is possibly insula.
insula.
Okay, so we have got a lot of areas covered. And the final diagnosis is okay. Can you see this?
Yes, sir, I can see, sir.
Yes. Now left eye is abducting, but left eye is not abducting,
Yes, sir.
and right eye is not abducting.
Yes, sir.
Abducted position.
Yes, sir. Yes.
Can you see?
Yes, sir, I can see.
I'm sorry I didn't play the video earlier. Sorry. You see complete ptosis.
Yes, sir.
So no,
കണ്ണുറന്നേ
patient not able to open the eyes.
കണ്ണു തുറന്നേ
Complete
ഇപ്പൊ കണ്ണു
ptosis.
തുറന്നേ
There are wrinkles on the forehead indicating thereby
വാ
she's attempting.
കണ്ണു
Yes,
തുറന്നേ.
The maximum they can.
കണ്ണു തുറക്കാൻ പറ്റണല്ലേ? ഒട്ടും
Yes, sir.
പറ്റണില്ല. ഉപ്പ കണ്ണു തുറന്നേ. ഒന്ന് തുറന്നു നോക്കിയേ. ശരിക്കും തുറക്കാൻ നോക്കിയേ. വാ വാ വാ.
So how do you proceed further? So how do you treat this patient further?
Sir, patient, if there is any edema, we should start an anti-edema measures so that because in posterior circulation stroke, there will be risk of worsening, sir. Because close to foramen magnum, there can be risk of obstructive hydrocephalus.
Yes, sir. We just went ahead with a doctor of the cranial vessels. Echocardiogram was done. Because there was some confusion regarding the blood supply of this region.
Okay, sir.
By
Posterior circulation.
vertebral basal territory.
Yes.
Some of the areas, the blood supply is by middle cerebral artery.
Yes, sir.
Okay, so possibly this is a posterior circulatory stroke, and patient improved on symptomatic treatment as you suggested. Patient opened the eyes and eyes started moving, not complete. Any hemiparesis also started improving, and this patient was put on a conventional treatment for CVA thrombosis, and patient was sent home on antihypertensive and diabetic medications.
Okay.
So this case is what all interesting points you gained in this case?
Sir, I learned about the blood supply, sir, to the midbrain. So I thought it's only by MCA and that's also by PCA. And I came to understand how to approach and localize the lesion, sir.
And coming to the blood supply, there could be aberrant vessels at any point of time.
Okay, sir.
And when you find multiple vessels are affected, always remember embolism is a possibility.
Yes, sir.
So always don't think we can localize with a single vessel. Sometimes it may be multiple emboli coming, or there may be aberrant vessels coming up supplying. That can also sometimes explain this.
Okay, sir.
But the interest of this case was the patient was brought to the hospital saying that he is unconscious.
Oh,
When he
okay.
started taking history, the patient was talking. Because his eyes were kept completely closed, the relatives thought that he is unconscious.
Okay, sir.
So their complaint was this man is unconscious, he felt unconscious. But he was fully aware what is happening around, was able to talk.
Okay, sir.
Okay.
Yes,
And
sir.
the moment you open the eye, you can see the right eye is deviated out,
Yes, sir.
down and out. That's very characteristic of third nerve palsy. Also, this case teaches us how to elicit fourth nerve in the presence of a third nerve lesion.
Yes, sir.
You concentrate on a blood vessel near the limbus and look what happens. Is the intorsion taking place or not? Intorsion is taking place, you think it is a normal fourth nerve. Otherwise, you think fourth nerve is affected.
Okay.
This case also teaches us how to localize hemisensory loss. The conventional teaching is when there is a brainstem involvement, it's a cross-hemi anesthesia.
Yes, sir.
But after certain level, both the trigeminal and spinothalamic is joined together. From there onwards, you can have hemisensory loss. But here, the thalamus being involved, that can also be explained.
Yes, sir.
So, the interest of this case is the clinical analysis of the case, cause of complete bilateral ptosis, sudden onset of ptosis, and why he is becoming blind. Partly because his occipital lobe is affected, partly because of maybe he has got hemianopia. So this case becomes very interesting. That's why we are discussing it.
Okay.
Any odd points?
No, sir. Yes.
Any doubts?
No, sir.
So thank you, Bala. Or
Thank you.
you have seen such cases earlier, I'm sure.
Sir?
You would have seen such cases earlier, no?
Yes, sir. Classically, all these CVAs, yes, sir, we see, sir.
And what is meant by Weber syndrome?
Weber's third midbrain third nerve palsy with corticospinal tract involvement.
Okay. And what's the Benedict syndrome?
Benedict, sir. One minute. Sir, corticospinal tract with subthalamic nucleus.
There will be tremor contralaterally, no?
Yes, sir. Contralateral hemibalances.
Any other syndrome you know in relation to?
Yes, sir. Claude syndrome, perinom.
Yes. What is that?
Sir, Claude syndrome is a red nucleus with odd nerve presenting with ataxia.
Rubral tremor, eh?
Yes, sir. Rubral.
What will be rubral tremor?
It's a red nucleus involvement problem, sir, where there will be tremor worsening with action, sir.
So it will be combination of extrapyramidal tremor and also you will be having interstitial tremor.
Yes.
It will be combination of the two.
Okay.
So that way this case is interesting in the sense that it teaches us a lot of lessons. Tell me some causes for isolated unilateral third nerve palsy.
Isolated unilateral third nerve palsy. Weber, sir.
Is any other? Suppose somebody comes to you with sudden onset headache and you find there is a third nerve palsy, what is the possibility you suspect? It says subarachnoid hemorrhage.
Yes, sir.
Posterior communicating artery, no?
Yes, sir.
Yes. And whenever there is herniation, you can have third nerve palsy.
Yes, sir.
Trauma is one important cause for third nerve palsy.
Yes, sir.
Ischemia again can have third nerve palsy.
Yes, sir. Superior cerebral artery aneurysm.
That's right. So there are a couple of causes for third nerve palsy. How will you differentiate between surgical causes of third nerve palsy from medical causes?
Surgical causes, papilledema will be there.
Surgical causes are commonly pressing on the nerve, and early involvement of the pupil is the hallmark.
Oh.
Medical causes like diabetes, what happens to pupil?
Pupil will be spared.
Why?
Pupil, sir, vascular supply of pupil and now supplying the pupil will be very peripheral.
So pupillary fibers will be in the periphery of the nerve and it gets collaterals from different directions.
Yes.
No?
Yes, sir.
So when the vessel is occluded, it's the central part that is gone. When the peripheral is affected, you get
collateral
involvement. And when there's a tumor or something like that, it will be pressing the periphery. Pupillary fibers are early involved.
Yes, sir.
So summarizing, this is a case of CVA, of a post-circulatory stroke. To start the blurring of vision, then he fell down, he had hemiparalysis and bilateral ptosis. We found third nerve palsy, sixth nerve palsy, seventh nerve palsy, hemisensory loss, and we localized the lesion in the brainstem, post-circulatory stroke, and he improved on treatment.
Yes.
Thank you.
Thank you, sir.